Hi, I'm Ted Dinsmore, President of Surgeon Technologies. Today, we're continuing our series on technology and healthcare, and I'm joined by Anne-Marie Biernacki, from one of the founders of ActualMeds. Hi, Anne-Marie.
Hey, Ted. Nice to see you today.
So, in this series, we focus around using technology in the healthcare marketplace, and this session today is going to be about in the payer space, which is a huge part of our healthcare system. We want to explore the application of ActualMeds and what you're doing. And we'd like to focus on your work with big data and how you determine the team-based medical management on the care continuum. Emery, can you start tell us about yourself and why you decided to start ActualMeds and why there's a need for team-based medical management?
Sure, happy to. So I am a serial chief technology officer. My original training and background is electrical engineering and applied physics, but I ended up pivoting into software 20 something years ago. And I've worked in the sort of bleeding edge of digital healthcare, as well as in early stage companies in commodities trading, platforms, supply chain, and consumer tech, all of which are cloud hosted or SaaS companies dealing with data transactions and rules-based information systems. That's my background. As a co-founder of ActualMeds, it was less about starting it than seeing some intellectual property that was out there at the University of Connecticut School of Nursing that with my co-founders, we saw an opportunity to have a tool that captured more information about the real status of a medication regimen for a patient, and then apply risk logic to that to inform clinician decision-making. That was a while ago. That was 13 something years ago. And we've come a long way since then to really extend this whole thing into a highly integrated, highly interoperable platform that pulls in data from a very wide variety of data sources, including claims, electronic medical records, various interview or structured data capture tools, to bring the data together, give a contextualized view of medication regimen, automate risk assessment and medication context, to apply clinical and or business rules such as formulary to the regimen. And then lastly, automate clinician workflow to get a better medication review result, better documentation, and much improved use of clinician time with robotic process automation. And we saw an opportunity to fix a lot of problems in the industry by doing that.
So as you looked at the current process and you were working on this, and you've talked a little about what you could, but there are some differentiators in what you've done. Can you just spend a couple more minutes on that?
Sure, they're huge. Typically, medication management is very fragmented. It's very siloed. It runs with incomplete information based on what's available. So at plans, at clinical practice sites and managed care, people are going off what they have on hand. They don't have a complete landscape. So we're bringing much more data together. We're creating a lot of process automation so that clinicians, specifically and mostly in our case, consulting clinical pharmacists aren't spending time on data curation and documentation and scribing, but can focus on applying clinical expertise and best practice. We are also working in an integrated way across a number of different data partners. So we're trying to work to reduce silos, especially for complex patients that have many points of care or many transitions of care. So workflow streamlining, as well as then capturing full longitudinal data so that we can develop context over a patient's care and not have each episode be a standalone artifact of information. So streamlining, consolidating, moving past things like spreadsheets and lots of manual labor to get better clinical resolution of risk and much more efficient use of clinical resources.
And what kind of, when we talk about the patient care, because that's the ultimate thing we need to focus on in healthcare, what kind of results have you seen, and have you got any feedback from what you've received on that?
Sure, we've seen it in two tiers. One is improved resolution of clinical risk. So with automated risk rules, we can capture things that might not be captured even by a talented, experienced clinician, because we're capturing all the data. We're able to automate interactions, duplications of therapy, non-standard information based on optimized care adherence, based on a look back over several episodes of care or refills of a medication. So we have quite broad clinical context. That has a direct impact to the patient, as does the completeness of information. In terms of best available resources applied to clinical care, by applying a lot of process automation, we can take clinicians and put them into clinical work as opposed to spending time shoveling data around, spending time documenting. Automated documentation, automated longitudinal histories, analytics and reporting let us mine the population information so we can do both better individual care, better use of resources doing that management of care, and then better view across populations to see them all performing as a whole.
And we've heard so many times clinicians talk about, I'm spending too much time on a computer. If we don't get, let's just say the scenario, if we don't get our hands around this problem of all this data, what do you think the future would be if we don't do it? And then with what you've been doing, how do you see it differently?
Well, the challenge we all get is it's very easy to get caught up in more data is better. More data isn't better. What we need is information, not more data. And so what happens is, as there's more fragmentation, that becomes a bigger and bigger risk in clinical care. It continues to bog down. You mentioned it yourself, I spend too much time at a computer and not enough doing patient care. People are becoming slaves to the computers versus the other way around, which is the way it should be. So by applying the automation, by focusing workflows where you have clinical input and the mechanics of curating, capturing, managing, shoveling data around, obtaining longitudinal reports is done by the system, we can reduce fragmentation. We can improve focus. We can turn all of that data into actionable information as opposed to more stuff I have to wade through. Reduce time on task. So in terms of clinical resolution of care, we've seen up to 30 to 40% improved resolution of risk.
Wow.
We have seen in some cases up to 60% improvement in throughput in a episode of review with that improved clinical resolution of risk. So better results, less time on task by the clinician.
And how to use the technology? We've worked together for many years on the technology side, full disclosure. But how are you using this technology to achieve these goals? Great results, by the way.
Thank you. So one of our big things is putting in these tiers of robotic process automation. We've built a work queue environment that automates when a patient comes into the system, what kind of care episode they're having. Is it admission, a discharge, a structured review based on a particular use case like chronic care management. Queuing those patients up in that work queue, we're able to look at patients that are simple and pre-populate or pre-package some of the information that has low risk to pre-assemble. So a clinician can go in there, everything's assembled for them. The data is contextualized. We've harmonized it across the variety of sources. They're not doing mechanical capture. All that's going behind the covers. They can look at the presentation of risk. There are hierarchies of risks. There are structures of how different risks are organized, whether it's clinical or financial, what have you. And by pre-assembling a lot of these components or indicating where there's been no change from prior status, the focus can go to where there's change, where there's a high degree of acuity or a high degree of variables. So we keep lopping off, if you will, many more branches of low-hanging fruit to structure that encounter better and then present that longitudinal history in an easily accessible way for reference. The process automation and the automated risk roles kind of really are the heart of our system. The ability to slice across histories and mine that data gives it richness for broader implications in population management and organizational performance.
It's great to see the technology being used to improve patient care. I know there have been many standardizations have been put in place in data integration, such as FHIR, HL7. We've all been through all the standardizations. Any of these things that you feel when we talk about standardizing data in the healthcare and getting data from one system to another, that really could be a game changer in what you're doing?
Absolutely. Well, as you know, Ted, we've been using these data standards from the beginning pretty much and implementing them. And what we've encountered isn't that it's not about having more standards. It's about actually leveraging the standards that are out there. And I think what I'd love to see is better, more consistent, more comprehensive application of the standards, I think is the challenge we see. Lots of times where you see people doing standards light, they kind of do a nod to a CCDA or an HL7 file, and then you see that they've done customizations or truncations of that record.
Right.
So we find ourselves having to compensate for that in terms of pulling that data in. And it's the sort of thing that it feels a little wasteful across the industry and the ecosystem.
Yeah.
So I think implementation and adoption of standards, people are moving that direction, but we still have a lot of work to do. There's a lot of lip service, but there's not a lot of follow-up on that whole talk about standards. And you and I have been at a lot of the conferences, and a lot of really good work being done, but I think there's still more work to be done out there. I also think that the sort of standards for testing when people are interchanging data, that would be improved, because setting expectations on how the data should perform, there's sort of multiple levels of interoperability, as we all know. One is the mechanical standards. It's the plumbing, it's hooking up the pipes.
Right.
But the semantic interoperability of data is also its own set of challenges. And it doesn't help if you've got great plumbing set up if you're getting data sewage instead of potable data water. And that's kind of one of my
drinkable water, right?
Drinkable water, yes, exactly. So that's kind of one of my data beefs. I think lastly, better frameworks for data governance around data liquidity. Organizations really struggle to unleash the data efficiently, and we have a really challenging set of balances to strike in this industry between very real threats in terms of security and data privacy and HIPAA and compliance to best practice in security, and making the data flow to actually render care. And I think we need sort of better communication between the interoperability folks and the data liquidity folks and the security and privacy folks. Those two worlds are very siloed, and they make it very challenging to thread this needle. And it's been something that, as an organization, we've developed a core competence on threading that needle out of necessity.
Well, thank you so much. And it's great work that you're doing. And it does help the clinicians at the end of the day, and patients. That's the most important message here.
Absolutely.
And just thank you so much for your work and for working with us for the past many years. So we really appreciate it.
It's been a pleasure and an honor.
All right. Well, thank you very much. And we'll have a new series, next series on technology and healthcare series soon for everybody else. Thank you, everybody, for listening.
Thank you.